welcome Dr. Alan Yeasted.
Thank you.
This is our second in a series of day in the life of hospital administrators and executives, and I've had the opportunity to work with Dr. Yeasted for the last 4 years at St. Clair Hospital, where he's the Senior Vice President and Chief Medical Officer for the hospital, and I appreciate you being here today.
Thank you, Holly.
We're going to be going through a series of questions of what it's like to be a chief medical officer and some of the challenges you have on a day-to-day basis. Could you describe to us how you have made your way to be a chief medical officer? You've had opportunities along the way, and if you can let the students know what those were.
Sure, I'd be happy to. I've been in practice for now about 36 years, and during that course of time, I was always interested in administrative matters. I was in practice in internal medicine with partners in Mount Lebanon for a very long time. And during that time, I became involved with the County Medical Society. And when you have a job like that, you get to learn how doctors think more than just working in a practice. I became eventually an officer in the County Medical Society, and at that time went on to become the president and chairman of the board of the County Medical Society, all of which in one sense are administrative jobs for physicians. You get used to working in a meeting setup where you have to watch other people's responses to things more than just taking care of patients. In addition to that, I was involved with the American College of Physicians, which is the organization that the internal medicine doctors across the United States belong to. And again, once again became an officer in that organization, and you start to develop a feel for administrative work. I had looked at the job at St. Clair many years earlier when it was available, and at that time felt that I was still too young to leave my position in practice, and so waited until it came up, and I was about, I think, 52 at the time when the job became available. The board of directors had asked me if I would be interested. I was a member of the board of directors at St. Clair at that time, had been the president of the medical staff of the hospital, again, a semi-administrative position, and felt that it was an opportune time to take advantage of the situation, and became the chief medical officer at St. Clair.
Tell us about your educational background.
Well, I grew up in Toronto, Pennsylvania, and so I'm a Western Pennsylvanian, and I've always been here. I went to St. Vincent College in Latrobe, Pennsylvania, and from there went on to the University of Pittsburgh Medical School. From Pitt, I stayed in Pittsburgh. I had a family at that time, so we wanted to stay in the city where both my wife's family and mine were from. So I did my internal medicine training at Mercy Hospital in Pittsburgh and finished there, got my board certification, and went into practice in Mount Lebanon.
Perfect. Explain a typical day in the life of a chief medical officer. I'm sure typical is not really the right word. Yeah, there probably isn't anything that's extremely typical except that it's very busy. I think that would be the typical part of my job. It certainly is a job where you cannot predict when you get in the morning what will happen. You will hear things throughout the day. Events happen with other physicians that will change what you intended to do. But to be fair, we would probably start most days 7 o'clock meetings, because that's when physicians can come, and also board members. So you have many board meetings that you need to attend. So the day starts about 7 a.m. And it starts. I mean, it isn't like you come in and start to read the newspaper until everyone else shows up. You actually literally will start working at a board meeting or a physician meeting. And we work on the problems of the hospital at that time. If there are certain, let's say we want to improve our infection rate, we may have a morning meeting with the surgeons to go over our infection rates and explain to them what we're trying to do and how we can improve it. If it's a board meeting, it could be a finance meeting, it could be a meeting of strategic planning purposes, or it can be a quality meeting. So those are the types of things that I would be involved in early on in the day. As the day progresses, things happen. Quite honestly, you answer a lot of emails from other administrators and from hospital personnel. They ask you as a chief medical officer to review a lot of things that are written. They want to put a memo out to the physicians. That would come through me first, and they'll say, do you think this will be accepted? Do you think this will be read by doctors? And oftentimes you're editing other people's work before it gets released to the physicians. And then throughout the course of the day, quite honestly, things happen. I mean, I think that's the most interesting part of the job. You'll get a call from someone that a patient is upset about a physician, and you have to investigate that, take a break from what you're doing, get the medical record out, review it, sometimes go talk to the patient or family.
and explain that, this is what happened, and this is how we will correct it. And then throughout the day, you'll have meetings with other administrators and other people, people from the operating room. You could have meetings with people in the infection control department, with the quality department. And again, I mentioned quality several times because in one sense, that's what a chief medical officer's job is to do. It's to make sure that the quality of the care delivered at the hospital is what we call at St. Clair university quality. We expect our physicians to practice the same way they would if they were at any university, and quite honestly, some of your day is reviewing that and making sure that that occurs. There are other things that happen during the day. You have to take care of credentialing of new physicians. Sometimes problems will arise. We can't get this recommendation from somebody. And the other thing I do, quite honestly, is I know a lot of people in Pittsburgh, having been involved in so many organizations. If someone calls and says, I can't get in to see somebody, can you get me an appointment? I'm able to make that call. So you're sort of at the service of the board of directors, of the other administrators, and certainly of the patients in the South Hills of Pittsburgh.
Now, you mentioned your involvement with the medical staff, being an administrator, and what's your involvement with the president of the medical staff, and being an administrator, has that caused some conflict between the medical staff because you are now on the other side of...
That's a wonderful question. And I would say for the first, I'd say at least maybe 5 years, maybe even a little longer, you're not really accepted as part of the medical staff when you take a position in administration. What has helped me over the years is that I never gave up practicing medicine fully, which many administrators in my position would do. That has helped to gain the confidence of the other medical staff members. So I still wear my white coat. If I leave my office, I put my white coat on. I'll go out and still see patients in the hospital. And Holly, as you know, having been at a hospital, you learn more on the floors than you ever do when you're in your office. So one of my recommendations to all young chief medical officers is make sure you go out on the floors. Doctors will see you there when you're looking at a patient's chart, or at the computer nowadays, and they'll tell you things that they would never think of taking the time to walk into your office and tell you. So you learn much more about the pulse of the medical staff when you are out on the medical floors working clinical medicine than you ever do in your office. So to answer your question, yes, it is a problem. I've had doctors say to me when I'll go to a meeting off-site, for example, being here this morning. I could go back to work at, say, 9:30, having started at 7 a.m. somewhere, and they'll say, oh, that's a pretty nice job coming in at 9:30. You learn to accept that, and you don't let it bother you because you know how hard you're working. And over the course of years, when they see your car in the lot when they get there, and they see your car in the lot when they go home, they start to learn that this isn't an easy job to be a chief medical officer. It does take a lot of time, much more than I thought it would when I took the position. Now, adding in medical practice on top of that, of course, I spend even more hours. But I think if you continue clinical work, and the physicians on the medical staff understand that you deal with the insurance companies, you deal with patient problems, you deal with families, you deal with scheduling, they're much more acceptable to you as a medical officer.
You mentioned insurance, and the class we're talking about insurance coverage and the Affordable Care Act. Have you seen changes in the way you practice or over the last 10 years as far as patients and insurance coverages and difficulties in getting people covered for certain procedures?
Certainly, but that's not related to the Affordable Care Act. The answer to your question is yes. It's much more difficult now, since the era of managed care, to get patients a CT scan if they need it, an MRI if they need it. But for the most part, if your reasoning is sound, you'll get the test approved. It just takes extra time to do it. And extra time can be up to about 20 minutes of your day, which can be significant when you're seeing patients. From the Affordable Care Act standpoint, I've seen patients worry more than they did in the past about what their insurance will be. But I haven't seen a change in the patient when you walk in the room and you close the door and you're one-on-one with a patient. That hasn't changed in my entire career. That is still the same relationship, the same, I will call, warm relationship that you have with patients and their families that you've always had.
Now, you've talked about the importance of quality, and without money, you can't have high quality. So as far as what's your involvement been with the budgeting process at the hospital, and how do you get involved in it?
Yeah, well, you're involved very much with the physicians and what their needs are in a hospital, and you need to balance those needs as a physician administrator with the needs of the overall hospital to make sure that we stay financially sound.
doctors will probably never get the concept that if we can make money as a hospital, we can reinvest and buy the equipment that they need to take good care of patients. From a physician standpoint, and I truly understand this, having been on both sides of the aisle for this, that they think that hospitals can just buy anything they want because they see a lot of investment on a hospital side. As you and I both know, having been on the budget side, we balance a request of maybe $30 million of requests each year and have to narrow it down to 10 to 15 million, which cuts out a lot of equipment and a lot of changes that doctors would like to see made. But you have to explain to them that it's all in the future and we're improving and we're continuing to see progress, and maybe they can't get 8 new scopes this year, but we can buy 6 or 5. And eventually they begin to understand that if they trust you. And I think that goes back to that trust factor that I think a chief medical officer has to develop with the medical staff. So when you never give them any bad information. I mean, always, you can give them bad news, but not bad information. Never lie to them. And that's been my philosophy since I started. If you always tell them the truth, they know that at least you have their best interest in mind, and sometimes we just can't afford the things that they would like us to have.
I know within the budgeting process, you have to do some forecasting, and I know that's an area that that you're not real pleased with, on having to forecast for the next year, but can you explain some of the forecasting that you have to do?
I will. Yes, Holly, you're absolutely right. It's not my favorite part of the job, but we will sit with the senior managers and look at the volumes of each physician by specialty, by name, and we'll try to decide what they're going to be doing next year, probably at this time or even later, because we start to budget in January and February of each year, into maybe March, and we're predicting what a doctor's volume will be the following June. Not 3 months later, but 15 months later, which I find totally unpredictable as a doctor. It's not a thought process that we are trained to do when we're in medical school. And I say that because if you think of medicine, yes, we practice preventive medicine. Yes, we explain to people why they should do the things that they do. But for the most part, if you're a physician, what you're seeing is people coming in and saying, this hurts, or this bothers me, or I have this problem, and we solve it. We don't predict what their problem is going to be a year later, okay, because we don't know what the human body is going to do. In healthcare, however, the finance people believe they can predict how many operations someone's going to do 10 months later. Believe it or not, they're actually fairly close to that. But I always look at it and say, but the doctor could get sick, the doctor could leave the area, anything could happen. But from a budgeting standpoint, Holly, you're absolutely right. We have to try to plan the number of patients that will come to our hospital next year, the number of operations a doctor will do, the number of admissions someone will have, the number of observation patients we will have. And I'm always amazed, as much as I complain about it, and Holly knows that I do, I'm always amazed that when you see the budget the following year, we're fairly close to what we predicted.
Average length of stay goes into play with the budget, and how have you been involved in as far as the reducing the length of stay?
Well, reason the average length of stay goes into the budget is it determines our patient days, and patient days determines how the nurses have to staff the units. So it's very important, as you say. And we've been very fortunate at St. Clair Hospital because we've been able to decrease the length of stay, and we've done that by knowing the data. If you have the statistics in front of you, and we have tools now that we can sit with the physician and say, this is your length of stay, and this is what the national average is for the same type of patients that you have. In the old days, all we had was length of stay. And length of stay, we'd sit down with every doctor, and to every physician, without exception, they would say, Holly knows what I'm going to say here, my patients are sicker. Okay, they've always said that. But with the new data that's now available, they can class the patients based on severity of illness and compare that severity of illness with the length of stay and realize that a very sick patient would be in for 7 days and a not so sick one will be in for 2.5 days. And when they put all that into the computer now, we can sit with a physician and say, Dr. Hampe, your length of stay, okay, is 5.1, but your colleagues that have the same type of practice as you have a length of stay of 4.2. Can you explain that to me? And that's made a tremendous difference with our physicians. And they realize that we're not just trying to drive down length of stay, but to actually provide very good care in a very efficient manner. And we've had quite a successful program at St. Clair, and our length of stay has really gotten, and you don't know this now if you've been there, it's below 4 now. It's about 3.9, which is really quite good for internal medicine.
Evidence-based medicine. Now, what you're talking about kind of lends itself to that as far as looking at the way physicians are practicing and comparing them one to the other. Evidence-based practice comes into play some?
I think evidence-based practice is the key for what we need to do in this country in the future to practice really high-quality medicine. We need to have the evidence in front of us. I do believe that over the past, I will use my term, 5 years, I think physicians have come to realize that there's a lot of information out there that wasn't available to us before. It's instantaneous now on the internet. You can look things up and find out what the latest information is to treat a particular illness. And there isn't a physician on our staff, I would think, that doesn't have a computer with them up on the floors, and when they come to any question about does this drug interact with something else, you just look it up, you know right away. So the evidence is there now to treat illnesses. Yes, patients do have differences, but for the most part, if we can try to use the knowledge that's available to decide on the proper therapy for patients, we will have better patient outcomes, higher quality, more satisfied patients, and quite honestly, a lower length of stay because we will be more efficient. We will not order unnecessary tests. We will order the proper test to get to the diagnosis. It will treat the diagnosis appropriately, and patients will do well. So you are absolutely correct. Evidence-based medicine is here to stay. It should be here to stay, and we will use that as much as possible at our hospital.
We've been talking in the classes about value-based purchasing and the government looking to go from volume to value-based. What's your thoughts on that?
The concept is very good. I think that the implementation sometimes, unfortunately, shifts some of our medical care to thinking more of documentation for the government instead of documentation for good patient care. As I've said many times, when I order the proper drug for a patient and they get better, whether I document that or not really doesn't change the outcome of the patient. It's very important, however, for reimbursement and making sure that we can show other people that we're doing the right thing. So doing the right thing is obviously the most important. But in addition, because of the new payment models, you do have to document that, and physicians will balk somewhat at this, and that is a problem you've dealt with and I've dealt with. They say, I'm doing the right thing, I just don't want to write it down all the time. But we need to do that now. And again, there's always a transition when these things come out. Physicians always fight it, they want to keep doing what they're doing. But over the course of time, they begin to realize that it wasn't that much of a duty to add some things in. And we have as much as possible at our hospital, and I think that also keeps us on very good terms with our medical staff. We've offered them as much help as possible to make this a painless transition. Because if you don't do that, you have a battle every single day. But as you know, when you were there and at the time that I've been there, we've tried to make it as painless as possible to do the right thing, because then we get much more cooperation.
We've been talking about patient satisfaction being a part of value-based purchasing, and the students have recognized that it's many times not an objective, it's very subjective. And hospitals getting reimbursed based on patients being satisfied. You could have the complainers that complete those surveys. And have you seen how has patient satisfaction played into your thinking as far as value-based purchasing, whether it's a indicator that would be something important?
Well, as a physician, I would say it's not as important as providing the right medical care. As an administrator, it's very important because we have to, because of the reimbursement systems now and the way we're judged, and of course, from a volume standpoint, you want patients to wish to come back to your institution. It's extremely important. I think the nurses, as Holly knows, the nurses certainly are much more important for patient satisfaction than physicians. We can ruin it, but we can't do as much to improve it as the nurses can. Mm-hmm. The nurses in our hospital have been wonderful. Our patient satisfaction scores are high. That's because we have extremely good nurses who understand it. Our physician scores have improved. And again, Holly, they have improved on the same way that we improved our length of stay. We share data with our physicians. We have their length of stay, we have their patient satisfaction scores, and we now provide it to them. And in fact, we have now at St. Clair provided
transparent.
Yes, transparent. We used to unblinded. We used to blind, everyone's score except your own. So you would know what you did, and you'd be able to see everybody else, but you wouldn't know who was who. Now we actually have shown on the screen at the medical meeting, here's everyone's length of stay, here's everyone's patient satisfaction score. That has made a difference. Doctors wonder, they're competitive, so if you can play on the competitive nature of physicians, you can get some good results. And they've tried to do better because they don't want to be the last person in line.
How about readmissions? We've also talked about readmissions and the government's stance on readmissions.
Well, the government's stance on readmissions is that they don't want them. Nobody wants them, quite honestly. As with many regulations, the regulation has preceded the improvement that we can achieve. So right now we're working from behind because it wasn't an important issue to us before. It was we took care of patients. If they needed to be readmitted, we readmitted them. Now that you're penalized for it, a lot of processes are being put in place to improve the readmission, to delay the readmission process. So we now have the concept, rightly so, that we're not just taking care of a patient in the hospital. We're taking care of a patient when they go home. It's our responsibility to make sure they get the right medication, that they take the right medication, and that they can stay in their home environment and not come back to the hospital. That's a change in concept for hospital care. As you know, we used to just take care of patients when they showed up until they went home. And again, the government realized that. The government expected us to improve. And there's a delay from the time that you're expected to improve until you can get all those new people in place and new processes in place. But it's coming. And across the United States, readmission rates are dropping because of that.
Changing directions, talking about strategic planning, and the classes we've been talking about the importance of strategic planning. What type of strategic planning have you been involved in at St. Clair?
Well, since I've been in this position, I've been involved with all the strategic plans we've done. The last one was probably about 7 years ago. We are involved in one right now. And you play a very integral part as the Chief Medical Officer. And of course, I am also a board member in the strategic planning process. It's a very, very important process and has become extremely important because of all the changes in Western Pennsylvania in the hospital systems and hospitals joining other organizations. And with the Affordable Care Act, that has put extra pressure financially on all of the smaller institutions to decide what their future will be. At St. Clair, as you know, we thought this was a very opportune time to start looking at our future and decide, what we needed to do to remain independent, which we have been all of our history since 1954. And we are in the process right now of looking at all of the data again, looking at all the financial data, looking at what has happened in the marketplace. We're looking nationally to see what has happened nationally, to compare that to what's been happening in Western Pennsylvania. If there is a comparison to what's happening in Western Pennsylvania, since we have the two large organizations now at odds with each other. But we're trying to find our new place in this scenario. Two large organizations, a very high quality hospital, St. Clair, within 7 miles of both organizations. How do we remain independent? How do we remain with the ability to provide very high quality care to the community? And that's what we're in the process of doing right now.
One of the classes that I'm teaching, we've talked about opening up a open heart program at the hospital that is in the case study, and some of the things that go into play whenever you're looking to do such a program. St. Clair, you were involved in the opening up their heart program. Can you explain some of the things that you had to do and getting the physicians involved? And
Sure, I'd be happy to. That was in the 90s for us, and what happened is that we did community surveys, and you asked people in your community and focus groups what we need to do to make this a better hospital. And I remember two specific things that came out in that time were cancer care and heart care. At that time, we could do a catheterization at St. Clair Hospital. We didn't do any surgery at all, so we couldn't intervene and put stents in if we needed them. So we decided, based on community input, that we would develop a full heart program, including cardiac surgery for coronary bypass and for valves, and improve our cardiac catheterization facilities so that we could put stents in an emergency if necessary. At that time, we started with 2 cardiac surgeons. We had 2 organizations. We did a RFP, request for proposal. We looked at different organizations and different medical groups to see who would provide it. Dr. McGovern's group at Allegheny General Hospital was very well known at the time, and so they provided a young physician out to our program. And at that time, 3 Rivers Cardiac, which was based mostly at Mercy, which was still an independent hospital at that time, they had a relationship with many of our cardiologists at St. Clair So they provided a surgeon. So to start our program, we actually had 2 competing cardiac surgeons, which was what the medical staff had asked for. Within, I think, a year or so, it became fairly obvious that one was going to be successful and one not. So the one surgeon pulled back to the original institution, and we remained with Three Rivers Cardiac, and that's been our group at St. Clair since that time. That has spawned a lot of changes at St. Clair. I liken it almost to the space program and a lot of improvements in making cars related to what they find out with making rocket ships. You find out different things that last longer and are harder materials. With the heart program, what that allowed us to do was increase the technology at St. Clair Hospital, and it sort of spawned, a lot of other medical care spins off of a heart program, which is very successful. Fortunately, ours has been quite successful. Our surgeon is excellent. We now have electrophysiology at St. Clair, and it all comes from better echocardiography, better heart catheterization, new technology in the cath lab, all of which you need to maintain a first-class heart program. And so that has really helped St. Clair get to a new level of technology in the area.
You mentioned heart and cancer. What's St. Clair done with the cancer care?
Well, we didn't have our own radiation therapy department at that time. We had just a private radiation therapist that was in the area who had his own business. And what we actually did at the time was if inpatients needed radiation therapy, we had to take them in an ambulance to the radiation therapy center and then bring them back after their care. Not so bad when it was 70 degrees outside, but it wasn't nice for the patients when we were down at 10 degrees and we had to put them in an ambulance, and they were sick patients. So we thought that it would be ideal to have something on campus. We talked to different organizations. Again, you can imagine, we talked to UPMC, we talked to West Penn Allegheny at the time. That still was before the Allegheny Health Network. And we asked them if they would be interested. And UPMC did express interest that they would be willing to put a radiation therapy center on our campus. And we had the space. We took a little bit of our physician parking lot, not too controversial at that time, and they built a new building on our campus. At that time, when it was first built, it was a UPMC facility at St. Clair Hospital. Since that time, we now are a joint venture with UPMC, and it's a 50-50 joint venture. So we provide, this venture provides the the radiation therapy for all of our patients. It's connected to the building, fortunately, so now patients don't have to go outside. It's been very successful. In fact, other than Hillman, I think it's the busiest outpatient cancer center UPMC has.
Perfect. Now you're part of the senior team at St. Clair. What's your involvement with the CEO and and the other members of the senior team?
Well, the CEO and I, of course, have to have a very close relationship and a very trusting relationship, and we do. We work closely as senior managers. We meet weekly, at minimum weekly, have a senior management meeting, and we discuss all the issues, such as employee issues, bonuses for employees, planning, strategic planning for the hospital. All of those types of issues come up. That's the senior management team. The president doesn't generally come to that. He comes usually once a month. We're getting ready for the board meeting. We prepare for our board meeting and our presentations. But on a daily basis, you really work with the CEO because many of the things that we are doing on the medical side are going to influence what the hospital does and vice versa. So we keep in very close contact with any physician problems that would arise, with planning for how we want to provide medical care in the community and for program development. So actually, the CEO and the Chief Medical Officer have to have a very close relationship, and one based on trust, that you know that what's going to happen in the hospital is going to be working both with administration and the medical staff, because otherwise it's very difficult to go forward.
At St. Clair, you're on the board of directors. You're a member of the board of directors as well as a senior team member of the board of directors. What's your involvement with the chairman of the board or other board members?
Well, I've been on the board of directors prior to having the job as the chief medical officer. So I have somewhat of a different position now on a board than you did before, because now, as Holly said, you go from just a board member and a physician on the medical staff to having an administrative position where the board determines your salary and your bonus, etc. That changes a little bit as far as the relationship. From the board of directors chairman, it's mostly through the CEO. So I think the board of directors chairman works more with the CEO in developing the programs for the hospital, and that would get filtered down to me through the CEO. Because I've been on the board prior to having this job and have been at St. Clair for so many years, I'm very close to the board chairman, and I usually interact with them quite honestly
within about probably weekly, that I have something with the chairman of the board. And we'll talk about issues with medical staff. I certainly would keep them apprised of any serious issues. As Holly knows, a board is responsible for the fiscal stability of the hospital. They're also very much concerned about the reputation of the hospital. So if there's anything that would happen on the medical staff side that could influence the reputation or make the newspapers, the news media, certainly I would inform the board, and we would work closely on that.
And making sure that everybody knows what's going on is
That's right.
important. What have you enjoyed most about the position with the Chief Medical Officer?
Yeah, that's actually a fairly easy question, and it's one that I've been asked many times. In fact, I'll put it a different way. Why did you leave medical practice and take a job like this? That's what patients would ask. And I think the answer is the same for both. I really have enjoyed that I've been able to change the medical care for an entire community. When you're in practice and you're as a physician, no matter how good you are, you're changing the medical care for one person every 15 or 30 minutes. And at the end of your day, you feel very good about what you've been able to accomplish. In a job as a chief medical officer, you can change the medical care for 250,000 patients by just making one decision. And I think that's what really is the nicest part of the job, that we can improve medical care, the delivery of it, the patient satisfaction, the quality for an entire community. And actually our community is about almost 500,000 people. That's probably the nicest part of this job that I've really enjoyed over the years, to see St. Clair come from a smaller, well-regarded community hospital to a nationally recognized hospital of quality.
What have you liked least about the position?
Meetings.
And doing budgets now.
There are a lot of meetings, and as physicians are so used to being in control and working hard and going from patient to patient when you're in practice, when you have to sit at a meeting and one meeting leads to another meeting and you're thinking, I have work to do, I've got to get these meetings over with to get my real work done. I think that's the most frustrating part. I understand after all these years the importance of them. A good meeting I have no problem with. A long meeting that doesn't accomplish anything, I'd rather be sitting at my desk or talking to doctors, or quite honestly out on the floor hearing what physicians are talking about and what their concerns are. So I think that's an easy answer. Meetings are my toughest, that everybody knows, but it's part of the job. You have to get used to it. I have on my desk, a patient of mine brought in a small little paperweight that says, I meet, therefore I am, because every time he would call me, I'd be in a meeting. So it's part of the job.
Days filled with meetings.
The day is filled with meetings. It is a very important part. It is an important part, but it is hard for physicians who are used to moving from room to room and seeing patients and going from bed to bed to sit at a meeting for an hour.
Yeah. Now, these are young future administrators. What would you be looking for if an individual came to your office and they were, you were looking to hire someone as an assistant to you? What kind of traits would you be looking for in that individual?
I think the most important trait in a job like ours is understanding physician behavior. It might sound simple, but doctors are so isolated, even in group practices, because they work independently. It's the way we were trained. At least at the time we were trained, and what most of the middle-aged doctors are trained, you weren't trained to work as a team member. Now they're starting to change that at the universities and train doctors to work more in a team. So everyone's individual. They think that, they worry about what they decide. They take care of patients. To take a job like this, you have to certainly understand group dynamics. You have to understand physician dynamics. You have to understand what a decision you're going to make, that you're going to promote this out to the medical staff, how that's going to be responded to. You could really get a medical staff up against you and up against the administration if you don't understand that before you present something. I think that's probably the number one trait, is understand physician thinking and how they are going to respond to something when some new regulation comes out.
What would you be looking for in a hospital administrator? Not necessarily a chief medical officer, but someone that would be looking to work in a hospital setting. Understanding physicians is important. What else would you be
I was
looking
going
for?
to say, understanding physicians.
That is still very important. But
If
there
you
may be
can't,
something
no,
other.
there is. I think from a hospital administration standpoint, you have to understand your role in the community. I still believe that as a board member, as a hospital administrator, we really have only one duty, and that is to improve the medical care of an entire community. That's what we've been asked to do. It's not our hospital. That hospital belongs to the community, and it's our responsibility to give them high quality care
as they would get at any university if they show up at our hospital. So I think to understand your role and not to worry about the politics, not to worry about the finances, not to worry about your income, it's what are you really there for? It may sound philosophical, but you are there to improve the health of a community. And I think that's the most important thing an administrator needs to remember.
Finally, what advice would you give to these students as they're continuing in their undergraduate studies and their graduate studies? Any words of wisdom?
One thing that I think is extremely important if you want to go into hospital administration is understand hospital finances. I think it's different than any other business. We're paid differently than most businesses. We have expenses that other businesses wouldn't understand. We have to deal with physicians who are not our employees for the most part that can make or break your financial stability. And I think that's the one thing I think if you really want to understand to be a hospital administrator, what you need to really understand is, again, what's the role of a physician, medical staff, and how do you understand hospital finances? It's a wonderful occupation. You know that, I know that. And the reason it's a wonderful occupation is you can do so much to help other people as a hospital administrator. It's a necessary evil, so to speak, because someone needs to run that hospital. It will not run on its own. So you have to get very good background in education of finances, physician behavior, institutional organizational dynamics. I think that's extremely important. You will deal with a lot of individuals. That's the kind of advice I would say is you have to really love the job. You have to almost be a vocation for you. If it's a job, there's a lot of jobs out there. You want to be a hospital administrator, to me that's a vocation.
And we talked yesterday with Mr. White as far as being patient and taking positions that will lead to a outcome that you want, and making sure that what steps you're taking gets you to that point.
Right. Actually, that's very hard for physicians, okay, as Holly knows, because we like to make a decision and move on. As a hospital administrator, you have to be looking to the future all the time. And that's, again, a transition from being a practicing physician to a physician administrator. You have to be much more patient and realize that the job won't be, that the decision won't be made by the end of the day. Very hard for us to understand, because we would just make a decision and move on. You have to understand that things have to be budgeted. In a practice, doctors would say, well, if I need a new EKG machine, get the new EKG machine, because it comes out of our pay, so it doesn't really matter, it's our decision. In a hospital, is it in the budget or isn't it in the budget? So it's a different type of concept. But at the end of the day, again, I must say, it's a wonderful occupation. Holly knows that, I know it. It truly is something you can make a very, very substantial difference in the care and the health of hundreds of thousands of people by being a good hospital administrator.
Okay. Thank you very much for your time.
Very welcome.
I will be asking you in your assignment to raise any questions that you've had from this interview. Opportunity will be for Dr. Yeasted to answer those questions at a later time, so that we can make sure that your questions and any thoughts that you have been addressed. So I'd like to thank Dr. Yeasted, and this is the second in our series of The Day in the Life of, and I appreciate your time in viewing it.
Thank you, Ollie.